Well, welcome everyone. My name is John O'Donnell. I'm the chair of the Department of Nurse Anesthesia at the University of Pittsburgh Nurse Anesthesia Program, and also the Senior Associate Director at the Winter Institute for Simulation Education Research. And tonight we're here with 4 of our esteemed alumni and faculty members who are here to tell you a little bit about how Pitt has influenced their careers. And so allow me to introduce each one of them first, and then we can go in the order of introductions. I've asked them to tell a little bit about their career and how the university and the education they received here has influenced their pathways as CRNAs, as leaders within the field, and also as educators. Our first guest that I'd like to introduce is Krista A. Bragg. She's currently serving in a dual role with the Allegheny Health Network as the Chief Operating Officer of both the Forbes Hospital and Allegheny Valley Hospital. Krista received her Bachelor's of Science degree, graduating summa cum laude and valedictorian at the University of Alabama at Birmingham. She obtained her Master's of Science in Nursing and Anesthesia and Nursing Administration, graduating cum laude for both at the University of Pittsburgh School of Nursing, and then obtained her doctorate in nursing practice with an emphasis on nursing administration from the University of Pittsburgh School of Nursing, and finally her MBA in Healthcare Administration from Patton University in Oakland, California. Krista, who we're very proud of, has held numerous positions throughout her decades of hospital leadership, ranging from management roles as a CRNA to her current position as an executive leader within the Allegheny Health Network. Krista has been recognized as a strong, patient-focused leader with an ability to inspire frontline caregivers, build high-performing teams, drive results, and transform cultures. Krista is a known national speaker on clinical patient safety and professional topics and has numerous publications. So help us welcome Krista. If you could just say a few words and let everybody know who you are, Krista.
Yeah, thanks, John. So blast from the past. I graduated from my nurse anesthesia program in 2000. So quite a while ago. I think for me, as you can tell, obviously I'm a big Pitt fan based on all the degrees that I've been able to obtain from there. I do believe in the school and the program. I think the nurse anesthesia program is probably the best in the nation. And for me personally, I feel like my training at Pitt, including the clinical portion of the nurse anesthesia program, provided confidence, the ability to be able to handle conflict really well, to handle stress really well, and then just the broad exposure to a variety of positions. You know, I remember vividly working in the OR and having that aha moment when I decided I wanted to be part of the system around me, which is why I went back to school. And I wanted to have impact on, you know, the way we take care of each other and the way we take care of our patients. And I think the other thing, just finally, is I think the University of Pittsburgh instilled a desire for a lifetime learning. I think that lifetime learning is probably one of the biggest benefits that you can get from a really great quality education. So I'm thrilled to be a part of University of Pittsburgh's alum. So thank you.
Thank you, Krista. The next speaker I'd like to introduce is Dr. Brent Dunworth. Brent Dunworth has a Bachelor of Science, Master of Science, and Doctor of Nursing Practice degree from the University of Pittsburgh, a triple threat, as well as a Master of Business Administration from Waynesburg University. Brent is the Director of Advanced Practice and the Chief CRNA at Vanderbilt University Medical Center in Nashville, Tennessee, with an academic appointment as an assistant professor. Prior to his current role, Brent served in a variety of CRNA leadership capacities at UPMC, including Senior Director for Nurse Anesthesia for over 8 years. Brent has received numerous awards, among them the Agatha Hodgins Award for Outstanding Nurse Anesthesia Student, the Pennsylvania Association of Nurse Anesthetists Didactic Instructor of the Year Award, the University of Pittsburgh School of Nursing's Outstanding Young Alumnus Award, and the Nevin Downs Leadership Award from Middle Tennessee School of Anesthesia. Most recently, Brent has been recognized as a fellow in the American Association of Nurse Anesthetists, or FAANA. Dr. Dunworth has lectured nationally on a variety of topics in nurse anesthesia and maintains clinical practice at Vanderbilt. And I would also mention that this is the very first and inaugural year for the FAANA designation, and Brent is one of the inaugural class. So congrats to you, Brent, on that honor.
Yes, thanks, John, and thanks to everyone for letting me be a part of this panel. It's an esteemed group of friends and colleagues that I'm glad to sit here with and have a great discussion. Pitt has been so influential in my career development. I still bleed blue and gold. my kids refer to the Pitt sports teams as us and we, and so they sort of are very connected to Pitt as well. But I think that particularly in my graduate education, leadership was really something that was put forward for all of us, and it was easy to be a leader. And if you decided that you wanted to do anything in leadership, it was fostered and really ignited, which really put me on a trajectory, I think, for the rest of my career. And so thanks, John, to you for that, and as well as the other faculty. I'm certainly a proud alum, and really continue my lifelong learning, as Krista mentioned, and tend to not be satisfied with my last accomplishment and figure out what we can do next. So again, great to be here.
Thank you so much, Brent. The next speaker I'd like to introduce is Mrs. Allison Lewis. Allie is a 2012 graduate of the University of Pittsburgh Nurse Anesthesia Program and a 2019 graduate of the University of Pittsburgh Executive MBA in Healthcare Program. She's also a BSN graduate from Pitt, so also a triple alumnus here from the university. She's been working as a certified registered nurse anesthetist for UPMC for 9 years, first at UPMC Presbyterian, where she also served as the assistant SRNA coordinator, and now as the clinical director of nurse anesthesia at UPMC Passavant since December of 2019. She is an adjunct faculty member at the University of Pittsburgh Doctorate of Nursing Practice Nurse Anesthesia Program, for which she gives various lectures and assists with workshops throughout the advanced practice courses. She was recently appointed to the position of vice chair of the UPMC Passavant Advanced Practice Provider Council. Allison has been published for her research in the genetics of pain and has presented her research at both national and international conferences. She is passionate about her work as a CRNA and also empowering APPs and future generations of CRNAs. Please help me welcome Allie.
Hi, thank you so much for having me. When I found out who else was on the panel, I felt like you were kind of scraping the bottom of the barrel with me, but I'm so honored to be here, and really feel so blessed in so many ways to be an alumnus of Pitt's anesthesia program. I think as a CRNA, you're really practicing at the top of your field, and Pitt really has given me the confidence to do that. And as a CRNA, I think it's just sort of ingrained in us because we're practicing really at the top of our field, and we're so highly trained that it's very natural for us to fall into a leadership pathway. And it felt very natural for me. I always have liked working with people. I love working with the students at Pitt and serving as their coordinator. And I found that while I love research and I also love teaching, I felt like I really enjoyed and thrived in working with people and helping them to succeed and looking to help them meet their full potential. So that's what led me to management and leadership and the current role that I serve right now at Passavant. I really think that Pitt gives you all of the opportunities and the tools that you need. Like Brent said, and Krista, we're huge Pitt fans at my family. I don't think my kids know that there's any other college other than Pitt. So we're huge Pitt fans through and through. And I'm just so grateful to be here today and to have graduated with 3 degrees now from Pitt. So good luck to everyone, and hail to Pitt.
Well, thank you, Allie. And I just have to correct you. It's not the bottom of the barrel. It's the cream that has risen to the top. And so, we're very fortunate that you have chosen to continue to work with our program, especially now that you're a CRNA director at one of our primary clinical facilities. So thank you. Last, but certainly not least, is my vice chair and the assistant director of our nurse anesthesia program, Dr. Michael Nefft. Dr. Michael Nefft is from Pittsburgh, PA. He was promoted in his work in the United States Army to lieutenant colonel, retiring from active duty in 2006. While in the Army, he served in a variety of clinical, educational, and administrative assignments. Dr. Nefft is an associate professor of nursing As I said, he's the vice chair of our Department of Nurse Anesthesia and our assistant director at the University of Pittsburgh. He served as a member of the university's Faculty Assembly and Senate Council, and has also served as a pro tem member of the Senate Educational Policies Committee and as a member of the Senate Policy and Bylaws Committee. Dr. Neft has also served as chair of the American Association of Nurse Anesthetists Practice Committee and its Health and Wellness Committee. He has served on the programs and membership committees of the National Academies of Practice as well. Dr. Neft is past president of the Pennsylvania Association of Nurse Anesthetists, one of many of our either alumni or faculty who have served in those roles, and has served on the Sigma Theta Tau International Region 11 Coordinating Committee. He's past chair of the Psychiatric Mental Health and Substance Use Expert Panel of the American Academy of Nursing, and continues to serve on that expert panel as a member. He's also a member of the American Academy of Nursing's Acute and Critical Care Expert Panel. Dr. Neft was inducted as a fellow of the National Academies of Practice in 2015, as a fellow in the American Academy of Nursing in October 2016, and like Dr. Dunworth, is about to be inducted as one of the first fellows of the ANA in August of this year. So help me welcome Dr. Neft.
Thanks, Dr. O'Donnell. It's good to be here. I appreciate the invitation, especially since I am not a Pitt grad. I took one course at Pitt once years ago. I've been on faculty for over 13 years, and the chief way in which my faculty role has influenced my career has been in the variety of different areas that I've been able to function. Aside from working with students in simulation in the classroom, I've also been able to serve on several grants, screening, brief intervention, and referral to treatment for interprofessional groups of anesthesia students with the behavioral health, nurse anesthesia, and School of Dental Medicine faculty. I assisted with the HRSA Nurse Anesthesia Traineeship grants now for many years, and also I served on the Expert for Nurse Practitioners grant. Being on faculty also stimulated my interest in research, such that I'm working on my PhD at Duquesne University. I never thought I'd be a lifelong learner quite at this age, but I am. So, and that's all due to my faculty role. I also get to help establish and revise program policies. And as Dr. O'Donnell said, I've served on School of Nursing and university level committees. I've been able to take a leading role in helping to prepare for accreditation visits by the COA and the AACN. In this role, I learned to place scrupulous attention to detail, reporting everything possible to justify how the program meets accreditation criteria. Currently, I get to spearhead several different initiatives. A point of care ultrasound. Our goal is to become a center for ultrasound excellence by 2025 in our department. We want our students and community CRNAs to be well versed in using ultrasound for peripheral and central line placement, peripheral nerve blocks, and point of care assessment in areas such as preoperative gastric content, fast exams, and bladder volume, to name a few things. I'm also working on implementing the use of the Lumis Insight platform, quote unquote, Body Explorer, as an integral part of the education, not only of our students, but also undergraduate nursing students. Students can see in real time the effects of their actions without waiting for third party to adjust the mannequin's physiology. They can actually see, for example, a heart beating in normal sinus rhythm, develop dysrhythmias, and they can treat those dysrhythmias via the system's smart sleeve, which allows the trainee to inject a solution recognized as a particular drug by the system and see its effects on the beating heart. I'm also beginning to research what a good wellness program for student nurse anesthetists looks like, with a view toward designing one that best suits our program and implementing it with Dr. Megan Dill.
Thank you, Dr. Neft.
Thanks.
And so if I could just summarize briefly, we have three very well established Pitt alums from a range of years, as well as one of our top Pitt faculty members here to join us. And I have a few questions that I thought we could perhaps consider as a panel. And so two of our panel members are senior leaders in healthcare systems, Dr. Bragg in the AHN network and Dr. Dunworth at the Vanderbilt, in the Vanderbilt system. And then we have a nurse educator or primary role nurse educator, Dr. Neft, and then a primary role manager of a significant clinical facility at UPMC Passman. So the question I bring to the panel is, I've been program director here since 1994. and there have been massive changes to how we educate students, the experiences they get, and the abilities of graduates as they come out of our program. What do you, as a panel, foresee in the next 10 years for the nurse anesthesia profession, especially as it relates to our training and education of students?
Well, I guess I'll lead off, and I don't know if we have
There are no easy questions for me, Brent.
No,
You know that.
but I'll lead off and say, first of all, I'm really excited to hear about the goal of having the Center of Excellence for ultrasound by 2025, and so I hope that there'll be the opportunity, right, to come back to town and take the course or courses that are offered, because I think that, you know, for a lot of us who are a little more on the dinosaur side, that was not even technology that we thought about, right? I mean, I remember learning axillary blocks as when you take the needle and you find the axillary artery, and then you go to the other side and put a large volume of local anesthetic, and then you come back through it and put some more, and usually they don't have a seizure and the arm gets numb. And now, right, we're doing things that we can see, and we're putting small volumes of local with much better effect. So the world is changing so fast, and I think that certainly as a profession, we need to respond to that and have that as an expected skill set for entry-level practitioners, and for those of us who need to pick up that skill. I'm excited to potentially have that opportunity. And I also think that, you know, in the past year, we've grown professionally by leaps and bounds, right? And the pandemic has sort of forced a lot of things upon us, and forced really sort of growth and evolution faster than any of us would have expected. And so it's a great opportunity, it's a great time to be a CRNA as always, and thanks for leading the way in this particular very important area.
So, of Megan Dill. So when you said her name, I was assuming, Brent, that's why you were laughing too. She's a wonderful person. So great partner for you, Michael there. So good. I think, John, to your question, I think that the world is trying to take advantage of all the things that we learned during COVID. I know that the healthcare industry is, for sure, whether it's ways we can leverage telemedicine, ways we can manage the patient experience differently. You know, it's really easy to log on and see your doctor in the privacy of your home now, and you don't have to drive or park. And so I think that as we continue to move through the anesthesia profession, we will continue to look for ways to provide more of a retail experience for our patients. You know, the younger generation, much more interested in being very informed, probably more maybe than mine or Brent's. And they're going to come to the table more and more with more information and wanting options. So I think that the field in general will advance through customizing the way we take care of our patients to meet the way they want to be taken care of. And then the last thing I would add, though, just for the profession, is I think it's going to be really important as time passes that we find ways to be value added to the hospital, to the health system, whether it's, you know, trying to belong to committees that are outside of anesthesia proper, and providing input and expertise into construction projects, you know, other areas outside of anesthesia, by continuing to influence and provide value and make there be value. I think that's how we'll continue to enhance our profession as well.
Thank you.
Thank you.
I think that the way, oh, sorry, Allie, go ahead.
Go ahead.
I think that the way we educate our students is going to change vastly over the next 10 years. I mean, we talked about point of care ultrasound, and also technology such as the Loomis Insight system that I discussed. I think students will be able to be much further ahead when they come to class because of some of the modalities that they'll be able to access remotely, so that their education experience, I think, will be richer overall. They're not going to come to class necessarily and listen to a lecture. They're going to be able to prepare at home with practical resources. such as using the Insight platform remotely, and then we bring them into simulation or into class and have deeper discussions about actual patient case management, as opposed to, I hate to see the word drier lectures. And then, of course, moving to clinical, as we talked about with the point of care ultrasound, they're going to use more advanced forms of technology with their patient care. And to Krista's point, we all need to think more globally, not just focus on our singular role in anesthesia, but we need to look at the whole organization and what value we can provide to the organization. Because the more value we provide and the more we're seen out in the other areas of the hospital, outside the OR, outside the surgery centers, the more people will realize what we're capable of, and the more we give to the organization, the more highly we're going to be perceived. Okay.
Hey, John, can I chime in? Can I chime in real
Please,
quickly?
go ahead. Yeah, of course.
There were no dry lectures in your classes. It was our running joke is to not make eye contact with you because you would call on us. And if you recall, I always sat in the back so that we wouldn't make eye contact.
You didn't escape. It didn't matter.
I know.
Yeah, there was no escape. You're absolutely right. But Allie, I'm going to butt in for just a second and just capitalize on two comments, one from Krista and one from Mike. And they sort of flow together. So, Krista brought up the point to say, hey, get involved outside of your traditional sphere. And I think that we've all done that. And I would encourage everyone to take that opportunity because, once people realize the expertise that we have as CRNAs, then they want more. And I remember the first time I joined like a perioperative services committee and someone realized like, gosh, he gets pre-op, inpatients, intra-op, post-op, ICU. He's got all of that, right, because of the experience that he's brought to the table. And you become real valuable. And then also, with your example of construction projects, those can be really rewarding. And oftentimes, I found myself in the middle of, architectural drawings or a walkthrough, and you say, well, why would you want to put that there? Because here's how the flow, right, of surgery works. And those can be some critical decisions, right? So the code button isn't placed behind a cart where nobody can find it, right, in an emergency. So great points, and I think as we get ourselves out there for all to realize the value that we bring, the better off we are. So Allie, over to you.
Yes, Allie, you're next.
Thank you. No, I like listening to everything that everyone has to say. What I would like to add, though, is that I think that COVID has really made two things abundantly clear, that our future generations are really going to be at the forefront, both because they are so experienced and skillful with the technology that we've seen has become so important with COVID, because everything's gone so virtual. And I think that our younger generations certainly understand that and are very skilled in these technologies. And the other thing is just the value, and Brent and Krista both spoke to this as well, but just the value that nurse anesthetists have to a hospital system and a facility. We at my facility were at the forefront at the height of the pandemic. We were as the CRNAs, we were the main responders to these airways. And then once they found that we could line the patients as well, we started doing that too, to help in the ICU, help in the emergency department. And so they really saw that these were skilled providers that are efficient, that are more cost effective in many ways. And so they really saw the value in the nurse anesthetists. And I think the more we empower each other and our students to look toward that independence and strengthening that skill set, gaining confidence that's going to help shape our future.
Thank you, Allie. I thank you all for those comments. And I think a common theme in there really revolved around the challenges faced during the last year of the pandemic and how we all had to make such dramatic adjustments, both educationally and in delivery of content, maintaining a high quality, but also assuring that students continued to be able to get into clinical when it was safe to get the cases they needed to graduate. And for those who are on the call who haven't heard me say this before, but we had 38 graduates in 2020 who were out for 3 months during COVID, and we were able to strategize, help them finish their DNP scholarly projects, complete the program with, on average, 777 cases and 2,300 hours or more of clinical experience, still finish by the end of Thanksgiving, have extra time to prepare for their national certification exam, and pass at a rate of 92% for first-time passage, to be compared with 85% national average. So that's just an example of how we all had to put together, and it wasn't just the school, it was us and our clinical partners and the support we have from our alumni that helped us through all that. So my next question is, we've learned many lessons, and I think I heard from Krista and also from Brent that maybe there are some things that aren't going to go back to normal or what used to be, because we found out that some of these technology applications actually are better or maybe more convenient. But my question is, what lessons will we have learned that will stay, and will we be ready as a profession to face the next pandemic? Because, you know, we were pretty lucky with this one. The case fatality rate was only around 1 to 3%, depending on what country you lived in and the therapeutics available. But should we face something more mortal, like an Ebola that's airborne or something like that, with a case fatality rate in the 70 to 80%, that's a whole different ballgame. So how are we going to be prepared? And will these lessons stick?
Well, I don't know if we can be prepared for Ebola at this level, so I'm not going to tackle that for sure. But
No, I'm not saying it's going to be, but I'm just saying.
I know.
Yeah.
It's terrifying just thinking about that.
Yeah.
You know, personally, I think that in the healthcare industry, one of the, well, there are many lessons learned this year, but one of them is some of the restraints that we've had in the past, we've placed on ourselves. So we kind of showed each other, you know, across silos and throughout the hierarchy, that we can do whatever we need to do. We just need to get the right people around the table and get it done. And so I think that that's been liberating in a way, because it's challenged us to look at how we work differently and recognize that the stuff that we were used to doing before that's not how we have to continue working. So I think that because collectively people, you know, gathered and became problem solvers together in different ways. I mean, at least in my organization with Highmark and Allegheny Health Network, the hierarchy is totally stripped. We're all on the same level. I mean, I'm in meetings with the president of Highmark, the president of AHN, and frontline workers as we figure out ventilator issues. And we're all together on calls on Sunday nights at 9:30. So I think that it's shown us collectively, probably throughout the world, that we have more power than we thought. We have more collective voice and effort, and we can get more stuff done together. And that doesn't really answer your question, other than I think we're freer now to look at different ways to take care of things like that than we thought we were before. Yeah. Does that make sense?
I think so, yeah.
Yeah.
Well, I think we definitely had the rust shaken off of us by the pandemic. And, you know, my experience was, you know, we see it coming, right? But we know that there are infections in China, and they were coming our way at some point in time. And I really remember taking, you know, the AANA poster that first came out about how to deal with coronavirus in the medical center, right, or in the clinical area, and putting it up, right, in common break rooms. And people just looked at me like, oh, you know, I guess, you know, maybe I'll look at that. and it hit, sort of like 100 pounds. And all of a sudden it was like, okay, this week COVID is here, and we are going to figure out how to provide a safe environment for our staff and our patients. And people were just scared. And, we were all scared. I don't think I've ever worked so hard in my life in terms of just planning and trying to figure out, where are the oxygen hookups and how many ventilators do we put here, and what supplies do we need, and do we have this? Well, at the same time saying, here's how we think based upon, the available science, which at the time wasn't much, how we could keep ourselves safe. So I think we learned how to deal with an airborne illness more so than we've ever dealt with before, right? I mean, maybe there's a tuberculosis patient here and there that we may have seen in our career. And now it's like everyone is on airborne precautions. So we learned to be nimble. We learned to, figure out, like Krista said, who do we call to the table to assemble the group who can get things done and get them done quickly and get wheels turning. And we didn't get it right. And we did have to modify, and that was exhausting for people, because they would say, well, you said do this, and now you're saying do that. And we're like, yeah, well, we learned that wasn't quite right, but it was close. So I think that brought out a spirit in people that I saw really bring groups together. And so we actually, our employee engagement scores went up dramatically in the middle of a pandemic. I think a lot of that was just because of good communication, and everybody felt like they were being treated safely, and that they were contributing to how do we get this done. And it really rallied a whole lot of folks together at the right time. So I think we learned how to work well together. I think we learned how to deal with, aerosolized viruses and so many other things. But are we prepared for the next one? I don't know. That is a tough one to answer because we weren't for this one.
I think our challenge is to not forget our lessons learned, but also not to get comfortable, because I think we were all very comfortable up until last March, and we got hit between the eyes with this problem. Excuse me. I know in the education realm, we had to learn to do things very, very differently, very quickly. I remember giving an exam at the end of last March through Blackboard, something I'd never done before. We use ExamSoft, but Blackboard was rather different. And got through that, got the students through that. I remember having Zoom rehearsals with the students because we hadn't used that before, and having them all sign on at a specific time so I could make sure they could sign on, they could hear me, etc. Teaching whole courses remotely was something very different. I mean, I used to being able to engage with students who were joking about being in the back row, so hopefully John wouldn't call on you. Well, I'm on to that. My gaze goes all throughout the classroom, and I purposely zigzag all over the place. So I get everybody, I'm equal opportunity with each quadrant of the classroom, but you can't do that on Zoom. I mean, I have the students' pictures in front of me, and I say, okay, I'll call on that one. I can't really see them. I can't take the time to change my view in Zoom so I can see the whole class and start scrolling through it. There's gonna be a lot of dead space and a lot of me not getting information across. So the bottom line of my rambling is that we can't get comfortable anymore. We have to constantly think about what could happen next and try and make ourselves as ready as possible.
So I agree. I don't know that we would be completely ready should we get hit with another pandemic, or God forbid a worse pandemic. However, I think that this pandemic really immediately forced us to prioritize things. Like Krista said, we were having meetings constantly with members of various teams across the hospital at all days, times, emergency meetings. And one thing that I found to be, I feel, helpful in keeping people's spirits up and keeping people informed was having a lot of sort of off-record meetings with the team and with the staff. informal question and answer sessions that I could provide them with as much information as I possibly could, so that they knew where we were, they knew what to do. And then once we devised a list of basically how to do these things, how to take care of these patients, and how to protect ourselves and each other, we practiced. So when the ORs finally slowed down, we had many sessions where we had, small groups coming into an OR and running through scenarios, how we would take care of these patients, how we would do these things with as little contamination and exposure as possible, because we knew as anesthetists, we're right in the most dangerous portion of this airborne virus that we really at the beginning didn't know a ton about. And then in my leadership role, we kind of had to really stay up on the policy changes that were happening daily and translate them for the team, because we would get email after email and have to somehow convey all that information to people who were scared, had a lot of email fatigue, and we were really at risk of having them be disengaged and, not handle things the way that we needed them to handle them. But yeah, it really put things in focus. And I think if we were to face something, down the road again in the near future, I think we would go back to making those priorities straight away, protecting our staff, protecting the patients, and trying to contain the pandemic as much as we could.
Yeah.
So Ali, I'm pointing to my wiser backdrop here, because during the pandemic, we never closed, because our mission is dual there, both support of the university and the students, but also the practitioners in our health system. Krista, I'm going to guess that the Star Center at West Penn also did not close and continued to support efforts throughout your system. And Brent, the Vanderbilt Simulation Center, I don't remember its name, but I'm sure that they also were part and parcel to all this. And Dr. Neft also mentioned augmented to virtual reality activities that could be used in support of what Ali's talking about. So you might practice something in an even safer environment like your home. So what was the impact of the simulation world on management of this pandemic?
Can I comment on that? Is that okay?
Yeah, please.
Yeah, so I think I have to say without a doubt that my training in the simulation sessions throughout our training at Pitt impacted the way my areas, at least our hospitals, responded. Because when we talked about, very catastrophic possibilities, such as putting patients in beds in the cafeteria, doubling up patients in the ICU, which by the way, we did have to do, that was coming in on the weekends, and people, employees, me getting into the patient beds with the ventilators and all the supplies and us practicing it. And just like you mentioned, Ali, in the OR, we did a lot of those things. How do you get from point A to point B and not contaminate anyone? How can we make sure without a doubt that when there's a trauma or an emergency birth, that everyone in the room spot on is going to have what they need and they're going to be safe? So we did a ton of simulation, big and little, throughout the entire year. And I know that that's because, at least in my areas, and I'm not taking the credit, but I'm just saying that was the mindset that the leadership team adopted to work through some of those scenarios. And I do think that, the Wiser Simulation Center and all those things impacted that.
We actually have a Wiser Center in Pasadena. It's sort of a branch of the main Wiser Center, as you know, John. And we were able to use dummies. And so we practiced intubating them. And in our small groups, we would go through the procedure and say, oh, well, I think it would work better this way if we contain the laryngoscope blade after we're done in this way. And we put the garbage right here. And we were able to go through these scenarios, which impacted how we set up our OR when we had a COVID OR set up. And then it also impacted when we had a COVID response team put together to do the intubations when our hospital became not quite overrun, but full of COVID patients. We had a CRNA 24/7 who would be responding to COVID intubations. And we had to work with the ICU to run through scenarios with them. When's appropriate to call? What's the best way to set up this process? Should we have a call in the morning? Should we have a huddle every single morning about, sort of like a rundown report of where these patients were, who was likely to be intubated, who was having code status discussions, things like that. And then we, another big hurdle was getting our team the appropriate PPE that we needed. Now we did have PPE, but it was a huge task to get all the key players fit tested and to make sure that they would have the appropriate N95 or PAPR when they were responding to these intubations. And then that was a huge task to organize and try to minimize waste at the same time, because we didn't know when this resource was going to run out. So these were all things that we were able to discuss and sort of pin down because of running simulations and practicing these scenarios.
Mike, did you want to add anything?
It's not so much with the simulation end, but Allie was talking about PPE, and I know back when our students first went into clinical last June, that was a big challenge because students would get fit tested, and then I would get phone calls because I cover all the clinical sites saying, well, so-and-so, none of our PPE fits them here. So then I'd be hurrying up, scrambling around, trying to find a place where the student could get the experience they need and the PPE that they needed. And even into the next rotation, making sure that students who had had trouble with the previous rotation were sent early so that we could see if they were fit testable in that particular facility with its particular PPE. And if they weren't, then I'd have to shuffle assignments around again. And that required a lot of flexibility on the part of the students and the clinical sites, because they're expecting these certain people and the students are expecting to go to these certain places. And at the last minute, I'm having to say, no, I've got to switch you and you and you in order to keep everybody in clinical and keep them getting the experiences that they need.
We were really fortunate. We received a really large donation of N100s. So all of our anesthesia providers have their own personal N100, and they just write their name on it and it's theirs.
Oh, that's
That,
so nice.
that worked out really well.
I'd like to just comment and say I think one of the real positives that came out of this, in a look forward, is that everyone realized that we figure things out really fast, and we're really good at MacGyvering solutions, and I think that will carry forward in a big way to to be included in problem solving and rapid fire problem solving in the future. So I think a lot of good came out of a really difficult time.
Yeah, I agree, and I'm very proud that all of us, both health systems in the area as well as our programs, have succeeded so well in continuing to meet our core mission, which is high quality patient care and making sure our students get a high quality education.
John, can I comment on that real quickly?
Sure, please do.
Since I've worked, for 10 years with UPMC, and now I'm really deeply embedded in Allegheny Health Network, both of which are very high quality organizations, absolutely, with great leaders. I just want everyone to know that when really important stuff is happening, those things don't matter to us. So throughout COVID, we had leaders from UPMC talking on personal phone lines with leaders of Allegheny Health Network, trying to work this out. What are you seeing over there? What do you need help with? What's going on in the community? So I think even, maybe this is not something that would be a popular conversation, but the reality is, as human beings and leaders, it did draw us together in the areas where it needed to. You know, the weekend after the synagogue shootings, UPMC and AHN leaders were all calling each other. Do you need anything? What can I help with? So, you know, I think that, you know, there's some, you know, the issue between UPMC and Allegheny Health Network, it is what it is, but competition's healthy. But when it really matters, I just want everyone to know on here that the leaders, we all take care of each other and we help each other when it's about our people and it's about our community.
But, you know, Krista, that's really good to know, because at the lower levels, no one necessarily sees that. So it'd be, you know, obviously we all saw Don Yealy and the head of ER medicine at AHN together in joint press conferences, but it's great to hear that all the other leaders were also talking.
Yep.
Yeah. I don't want to not remember that Maddie told me that she has some questions that have been submitted. So Maddie Dix, who is our School of Nursing Development Officer, is here also with us. And Maddie, if you could just tell us the questions that we have for the panel.
Yeah, absolutely. So thank you guys so much for sharing all of your wonderful expertise. It's so fascinating. Coming into this role, I wasn't entirely sure of the nurse anesthesia and anesthetist profession. So from my perspective, this is amazing to learn all of the great things that you guys are doing. Plus, as Pitt faculty and alums, I'm just so obsessed and excited about all the great things that you guys have done. So thank you. We did have one question sent in that was sent in early, that if you guys could discuss. So what role, if any, did crisis resources management and or simulation, we talked about simulation a little bit, play in developing your practice as a CRNA?
Well, as a CRNA, if I'm talking too much, John, just tell me to quit talking. But I think those roles, that training was extraordinarily important. So at another organization that I worked early on, where we had a huge trauma program, we practiced the first 10 minutes of traumas. So the first 10 minutes with, you know, the entire OR team, and we became really, really good at the first 10 minutes, which gave time for the backup people to come in and help us. So, you know, and that's just one example of many. I think that kind of training is really good for us, even as we manage stress when we're in leadership positions. You know, all of that plays into our ability to handle really tense conversations, confrontation. I think that when you're an anesthetist, you become really good at handling on the fly difficult situations and pushing back and drawing a line and being a patient advocate, and all that stuff really plays into anesthesia practice and leadership.
I agree. I think, you know, it was so influential in our development. And, you know, my class in particular, I mean, we were one of the first doing simulation before simulation was a thing, right? And it was, you know, this sort of room in the basement of Montefiore that was a little bit scary to get to. But that's where all the action happened. And, you know, we were well prepared to go into our first days of clinical, and we were well prepared, you know, to do crisis management, and the communication skills, I think, that were taught as a part of that were something that, you know, we've all built upon forever. And so, yeah, I mean, we did simulation before it was real. And, you know, John, that was certainly your commitment to realizing here's the future, and let's jump on board early.
I did all my training in the Army, and I also helped educate Army nurse anesthetists for years before I retired. And we actually used simulation also in our Joint Trauma Training Center in Houston, Texas. There was Tri-Service, Army, Air Force, and Navy. Sent rapid deployable medical teams there for 30 days before their deployments, or if they weren't going to deploy soon, they sent them there for training. And we had a simulation lab there in which we worked through trauma simulations, and then in real time, they took care of patients in the emergency room and the operating room, so they could readily employ what they had just learned. And it was really valuable for them to see that those kind of patients in real time, and to be able to prepare for them in simulation before.
I think crisis simulation and crisis training is so important, because not only is it good to run through scenarios that you very well could see at any moment in the OR as an anesthetist, It also, even though it's simulation, you still get the adrenaline rush. You still get, the nervousness that you would likely experience in real life with a real patient on the table. And it really brings to the forefront areas of opportunity for yourself. Like, I didn't really handle that situation that well, or I really broke down, and it shows you what you can work on to handle these situations so that you're more prepared in real life when you have a patient on the table. It points out where you need to call for help, and where also your strengths are, that you knew what to do, and you knew the algorithm to follow, or you detected a problem that maybe others did not. And so that, I think, helps to build confidence as well, which is so key when you're on your own in the OR with a patient on the table in front of you, and it's just you, and you're keeping them alive, and you're getting them through the most critical point in their life. So I think it's so important. I was actually just talking with a student today in the OR about their ACLT. I guess you guys just had ACLT sessions, and I still remember mine. And I was saying how when I was, you play these different roles. For anyone who doesn't know about this crisis training simulation program, you all assume different roles in the operating room. And I remember vividly being the scrub in the operating room with a patient with symptomatic bradycardia. And when we debriefed, I remember being so frustrated because I felt like I knew what to do, but I was not in that role. And now when you're in the CRNA role, you are the one calling the shots, and you are the one saving that patient's life. So I definitely think it's so important in your training, and it really will help you down the road.
Well, I think it also creates real teaching opportunities futuristically. And we did so much with the difficult airway simulation, right? And I became an instructor of that before I left Pittsburgh. And those are lasting things that are embedded in your mind, and you can sort of work the difficult airway algorithm forwards and backwards. And I found myself saying in a crisis situation to someone, no, when you can't intubate and can barely ventilate, giving more rocuronium is not a good idea. We really need to not do that. And really guiding others in an appropriate way. So I think it really is very perpetuating. I also want to say that I looked at the list of attendee names, and there's so many people on there that I know. And so hello to all of you. It's great to see your names, and thanks for tuning in.
Well, I would just kind of put a cherry on the top of the cake here by saying the very first simulation that I ran for our nurse anesthesia program students was crisis resource management. And now that I have 25 plus years experience, that was the wrong thing. The brand new students didn't need to learn how to deal with crisis. They needed to learn how to deal with the basic things. So we've backed up, and now we do a bunch of basic things, and then eventually crisis management. But that was an early idea that we had, that, hey, maybe this device is just to train people how to deal with emergencies. And now we know these devices and this whole industry can be used to train for many other things, like for COVID and infectious practices, and for doffing and donning and so forth. But certainly the crisis piece is one that sticks with people because it's very sticky learning, and you go through emotional experiences like Allie relayed, whether it's frustration or excitement or fear. Those are things that stay with you. And so I think that that's a great question, whoever asked it, because it's something you're definitely going to have to learn to be an anesthetist, but also something that's valuable across healthcare.
So, John, Brent, I'm going to tag on something you said. I'm looking at the attendees that are on the call because I had not done that yet. And I just want to throw out a big kudos, because a lot of these people impacted my career and impacted me personally. So Bettina, Judy Murmagus, oh my goodness, a blast from the past. Obviously, Megan, Joe Good, oh, that's wonderful. just wonderful people. So I think that's the other takeaway too of going to Pitt is we get to interact with really quality people, and they impact us and we impact them. And that's just part of the experience of going to the University of Pittsburgh.
Well, and I think that, so many connections get sort of rekindled over time. And I just spoke to one of Alan Miller James's colleagues from Atlanta recently, and so we realized we knew each other. Nick Bircher, great to see your name on there. Thanks for joining us. Joe Daly, he and I have talked recently, and anybody who's heading to Utah, I sort of send toward the way of Jordan Thompson. So good to see all of you and everyone else.
Yeah, Krista, Nick, and Joe, and Megan, and Judy are all part of our faculty now. So we're super, super excited to have such an experienced and diverse faculty.
That's wonderful.
Yeah.
So we just got one final question, if you guys are able to answer it. Why advocate for a DNP degree instead of an MSN degree, CRNAs, when there appears to be very little value of increased knowledge or skill set, and most importantly, no increase in salary?
Boy, I'm going to answer that.
That's a hard last question.
Well, I don't know who asked the question, but the idea that you don't gain knowledge or additional value to your career and so forth is simply, in my opinion, not correct. There is tremendous value added to being able to see a clinical problem and have the skill set to be able to address it in a structured and meaningful way in a project. And the comment about whether or not salary changes, well, that's true. But salaries didn't change when we went to the MSN level either. And so, the credential of CRNA is really what is the credential that you need in order to be employed. But the last comment I'll make is the argument as to whether we should continue MSN education or DNP education has been over for about 10 years. Every single program must be a DNP program by January. In fact, no program as of January could even accept a master's candidate. And so, it's essentially a moot point at this time. What we need to do, in my opinion, is make sure that our DNP programs are streamlined. And we're learning how to do that because it's a new degree, and we're making changes to our program, and other programs around the country are doing likewise to help their students get through that process, and importantly, get all the skills and knowledge they need to be really good CRNAs in the clinical area as well.
I just had this thought just a few days ago, and it's become very apparent to me the value I think that the DNP has brought to our profession. And we're really seeing that now that, some programs have been producing for several years, but content like leadership and crisis management and teaching and all of those things are now part of it, and these folks, as well as scientific inquiry and appreciating a research study for whether it's quackery or it's fantastic, this skill set is really present in the graduates across the country, and they're showing up in the employment setting, raring to go. They're like, yes, I want to give lots of anesthesia, but what else can I do, right? How can I get involved in, quality? I'm interested in teaching. Could I be a mentor? So it is really bringing a whole different candidate into the workforce, and it is really amazing, and it is clearly the future.
I was pondering this this evening, and the different things I might want to talk about came to mind, and this dovetails with what John and Brent have said about the skill set that we gain with the DNP. An example I thought of was, in your day-to-day work life, clinically, you would identify problems, and when you go to your boss and say, I think this is a problem, you need to go and with this possible solution or a possible way of assessing the problem and finding a solution. And I think the skill set that you gain in DNP education provides that. And that, I think, is the biggest pluses to changing from a master's framework to a doctorate in nursing practice.
I also like to add, as someone who does not have a doctorate, I think it makes you more marketable. I mean, we are in a very highly competitive field, and across the country, nurse anesthetists, I mean, you don't go into this field unless you're pretty much at the top of your game and you have the education and the qualities to back up a degree in anesthesia. And so I think you are going to be competing against these people for jobs, for opportunities, and having that doctorate, I really think it makes you more marketable. And at some point, it may come down to whether someone has a master's degree or a doctoral degree, and they may choose the doctorate degree because they feel that they've received additional education, higher education. Maybe they have the thought process that the skill set is superior, which it likely is because you're going to additional schooling. So I just think that while maybe you aren't going to see that reflected in your salary, it's certainly going to be reflected in your marketability.
Thank you, Maddie.
Yeah, thank you guys. Yeah, that's all the questions that we had. So I definitely want to be conscientious of everyone's time. But if you guys have, if any of the registrants or participants have any additional questions, you can feel free to email me and I can pass them along to our lovely panelists.
And Maddie, I just want to take a moment to say thank you to our panelists for taking the
Oh,
time.
of course.
Your extremely busy careers and lives to pay it forward for our nurse anesthesia program. It is much appreciated. And know that if you need anything from the Pitt Nurse Anesthesia Program, we are here to help you. And for all of our participants who are online, we're here to help you. Just reach out to us. I'm pretty well known for trying to turn things around. There's Krista. But it's very important for us to turn things around as quickly as we can to help you. Whenever you need new credentialing or verification of your education, we're there to help out.
Thanks. I just wanted to show my children's friends our old Narcomed there machine with the suction atropine.
We're still using that machine in the simulation center.
I love that machine. Are you kidding me?
Yeah.
Well, thanks again for the invitation to participate. It was great and great to participate with this panel. And thanks everyone for joining. And good night from Nashville.
Thanks.
Thank you so much.
Thank you guys so much. This has been wonderful.
Thanks, Maddie.
Absolutely. Have a wonderful rest of your night, guys.
Thank you.
Bye.